Perhaps my speaker volumes are low. So we will try and finish screening today, which is the last thing before your first internal exams next week. Just don't panic. Some people came back to me and said that the portion is too much, but just don't worry. This is there for every first internal. We have checked from the previous batches. The portion is almost the same, and it gives you an excuse to revise most of the lessons which are important from the exam point of view, the short notes, the long questions, and of course, please look at previous year's papers, what type of questions come, formulate an idea, and then you will be able to answer well. Reading is one thing, attending classes is of course important, self-revision is important, but then before the exams, what kind of questions come, which are more often asked, which are the short notes which are important, you must have a fair idea about that. And that will help you concentrate on some topics much more than the others. So screening for disease. Well, we have talked about the iceberg phenomenon in the chapter on health. There is an iceberg. Of course, 9/10 of the iceberg is below the ocean or the water level. Only 1/10 is available, which is the apparent disease in the community. The one which is below the water level is inapparent or subclinical or undiagnosed or carrier stage disease. What we can see in corona is actually an iceberg phenomenon. People say that the cases are so many, but what we don't realize is because of less testing, because of less screening, we don't have the inapparent, subclinical, asymptomatic, undiagnosed carrier people coming up in the statistics. So what best example can I give you other than corona? It gives a better idea of the spectrum of disease, the iceberg phenomenon, very important thing to know, a simple thing to understand, and perhaps a potential short note. Detection and control of unrecognized disease is the challenge for health workers, for community medicine specialists, for public health people. Since our public health infrastructure is so poor, we as a country could not diagnose many diseases of corona, many cases of corona, and therefore this is a typical example of iceberg phenomenon. How do we overcome this? Is by a good screening test. I hope all of you are getting the concept now. So we come to the all-important definition, which may be asked you in the Viva, as well as you got to write it in the exam in case there's a question, what is screening or define screening? The search for unrecognized disease or defects by means of rapidly applied tests. Please remember these words and mug them up. Rapidly applied tests, examinations, or other procedures in apparently healthy individuals, especially those not seeking healthcare. Class, try and understand and appreciate the importance of this important definition. The search for unrecognized, it's a search. When you screen, you search. What do you search? For unrecognized, undiagnosed carrier states by means of rapidly applied tests. That's why we have a rapid antigen or a RAT test in corona. And it cannot be a RT-PCR, which takes about 2 to 3 days to get the results. You have to apply a rapid test, examination, rapid test or examination. Like, in certain diseases, we have examinations. Like, for example, let's say screening for breast lump. We will ask the patient to have a self-breast examination and thus screen, or other procedures in apparently healthy individuals. We do screening in apparently healthy individuals. When he is sick, he is no more screened. He is diagnosed. He is investigated, right? So please remember this definition and remember it by heart and remember it for your life. For all of you are going to do screening tests in some form or the other in future. The examples I gave you already, and there are a few more examples, are like annual medical exams. Many of your parents will be in services where they have to undergo a medical exam every year. Individual disease screening, like we screen for breast cancer, I just told you, by mammography or something. We screen for cervical cancer by pap smear, or some selected group screening, like say we want to screen a group of smokers for early signs of lung carcinoma. or something. There is a difference between screening and diagnostic tests. All of you, if you have understood the definition by now, you will know it. Screening is done on apparently healthy, whereas diagnostic test is done on the sick. It is applied to groups, whereas this is applied to a single patient. Please appreciate, when you sit in a hospital, one patient walks to you in the OPD. Whereas when you go to a community, you set up a kind of camp and you tell one and all to stand in a line. One of them, they come to you, you screen, you send him home, the next comes, and that's how it is applied to a group of people. Test results are arbitrary and final in screening. Like you do a random blood sugar test and you say, well, your sugar is high, go to the hospital for a proper diagnosis. So it is arbitrary and final. Whereas in diagnostic test, the diagnosis is not final, but modified in light of new evidence. So it's a more dynamic thing. It is based on one criteria or cutoff point. We always have to have screening tests where we have cutoffs. Whereas in diagnostic tests, as I told you, it is dynamic. It is based on evaluation of a number of symptoms, signs, and laboratory findings. That's why your medical specialist, your surgeon tells you when you go for a clinic to correlate your symptoms and signs, your case taking, as well as the laboratory investigations, and then come to a differential diagnosis. So you have to correlate. Whereas in case of screening test, it is one test and you have a cutoff point where HB above 10, normal, HB below 10, anemia. So anybody whose HB below 10 is anemia. Further investigations will require the patients to come to the hospital and undergo more elaborate diagnostic tests. I hope you are getting me. The screening tests, obviously, they are less accurate, whereas the diagnostic tests are more accurate. The screening test has to be less expensive. If you take the example of corona, the RAT is much lesser expensive as compared to the RT-PCR, whereas the diagnostic test is more expensive. This is not a basis for treatment, whereas a diagnostic test, after you do a diagnostic test, you arrive at a proper diagnosis and you start the treatment. The initiative comes from the investigator or agency providing care. Your PhD guide or your MD guide tells you, go to so-and-so community and do a screening test. So the initiative has come from the investigator. The hospital wants to know that in its catchment area, how many people are probably hypertensive, and they conduct a camp for hypertension. You just measure the BP, okay? Whereas the initiative, in case of a diagnostic test, comes from the patient feels unwell or whatever, he comes to the doctor in the hospital and requests for a testing or for an examination. Some tests are used for both screening and diagnosis. The examples are tests for anemia, like I gave you an example of HB or hemoglobin, and glucose tolerance test. May be asked to you in the Viva if you are doing well. Name some tests which are both used for screening and diagnostic tests. Well, concept of lead time. What is lead time? This will be asked you in the Viva, or perhaps it will be part of a question where we say, what is screening? What do you understand by lead time? What is lead time? Well, look at the diagram or the arrow. This is taken from your book, Path. Once the disease has set in, the usual time of diagnosis or the final diagnosis comes along the straight arrow. Whereas in case you screen a patient here and you send him to the hospital for a proper diagnostic test, you gain time. So therefore, lead time is the time gained between onset and final critical point, okay? Where time lag between onset and final critical point is long, this kind of detection test is put in here and you gain time. I'll give you a small example. I start smoking. You do a screening test and tell me, don't smoke. You are liable to get some lung disease. I stop smoking and I don't wait for that 5-year period, after which I would have got the disease. So I gained 5 years. I also remained healthy. This is what is lead time. In case the question is asked to you, just say it is the time gained it is the advantage gained because of a proper screening test, right? So this is the lead time here. The arrow has now shown you the lead time, the first possible point of diagnosis and the final critical diagnosis done in the hospital. There is a time lag and you gain that time. That is the lead time, okay? Or the usual time of diagnosis, whatever. Well, the aims and objectives of screening: to sort out from a large group of apparently healthy people those likely to have the disease. I have repeated this again. Or at increased risk of disease under study, to bring those who are apparently abnormal under medical supervision and treatment. Out there in the community, there will be many people who are apparently normal, who are apparently abnormal. You do a screening test to screen those people who are apparently abnormal, and you bring them to the hospital, or you tell them, please take care, you are likely to get this disease, you may be pre-diabetic, please take care and get yourself diagnosed and start your treatment. Otherwise, in a year's time or 2 years' time, it may be too late. Earlier diagnosis and treatment may favorably alter natural history of disease. Remember what is the natural history of disease from the concept of health and disease chapter. Potential exam question. Disease, the natural history is in a significant proportion of those identified as positive. So that is the aim of screening. Remember, there are certain terminologies you need to know to differentiate between screening, case finding, and diagnostic test. Screening is testing for disease in those who are not seeking healthcare. Remember that. You as an investigator, you as a public health specialist, you as an authority, health authority, have initiated the screening program. Whereas case finding is use of clinical or lab tests in persons seeking healthcare for other reasons, like ELISA to see whether the pregnant lady has got HIV or not. So therefore, it is a clinical or a proper lab test. You don't use ELISA in the community to find out about HIV. It is too costly, it is not very rapid, and it is not used for screening. It is not feasible. Whereas in a diagnostic test, clinical or lab test to confirm or refute existence of disease in patients with signs or symptoms. So there is a difference between case finding. Case finding you can do by using your clinical acumen, by using the knowledge that you have about signs and symptoms, and corroborating it with lab tests if available. Whereas in diagnostic test, you have to confirm the diagnosis by use of a lab test. Screening, an altogether different ball game, I told you. The uses of screening could be asked to you in the Viva, could be a short note. In fact, let me not repeat, the chapters on health and technology are so important that every nook and corner has got a short note or a potential question. The chapter on screening is just about 5 pages, but it is full of potential exam questions. Case detection, that is called as prescriptive screening, okay, for your own benefit. We use screening to detect cases. Obviously, I told you that. We use screening to control disease, prospective use. Once we screen and we find that there are, out of 100 people, 10 people suffering from diabetes, we are controlling the disease in the rest of the community by separating these 10 and giving them proper treatment. Research purposes, obviously, screening is important for research and educational opportunities for awareness and IEC, information, education, communication, that is health education in short. These are the 4 uses of screening: case detection, control of disease, research purposes, and for educational opportunities. There are 3 types of screening. Again, an example question: mass screening, high risk or selective screening, and multi-phasic screening. Mass and high risk, I think you can understand. Mass is you just go to the community and you start screening the whole community, the whole village, the whole bunch of people. This is much criticized as it has to be backed with treatment. And secondly, it may become very, very huge burden on the health authorities. So high risk or selective screening. To high risk individuals only, we apply the screening test, or to some risk families which have got some risk factors. Therefore, it is something like you go to a shop with your mind set on buying a blue dress. You see several shades of blue and you select one. Instead of going to a shop with an open mind, which is like mass screening, and you like the red and the blue and the yellow, all three, and your parent says, no, you got to buy only one. I can't afford all three. Okay, and there is disappointment. So therefore, mass screening is not feasible every time. So we depend on high risk or selective screening. Then we have multiphasic screening. The word says multiphasic. Application of two or more tests in combination to a large number of people at one time is called as multiphasic screening. Remember this definition: two or more tests, okay, at one time. Two or more tests at any one time. Well, this is also not very feasible in a country like ours because of increased cost and no benefit in terms of mortality, morbidity reduction, and tests could not be validated many a time because we use some questionnaire methods and we say, okay, once you answer question 10 as yes, then go to the next section, something like that. I'm just giving you a small example. So multiphasic screening is application of two or more tests in combination, which is just to be remembered from the exam point of view. Now, criteria for screening, there are criteria for the disease and there are criteria for the tests, right? So we'll quickly go through the criteria for screening for the disease. Criteria for screening may come as a short note. Once it comes as a short note, please write criteria for the disease separately and criteria for the tests separately. And before I go to the tests, let me tell you the criteria for screening of the criteria of the tests, the screening tests. They are very, very important. Each of the terminologies you got to learn and learn for life. Life means till the time you remain a doctor, a practitioner. Well, the criteria for screening are: the condition should be an important public health problem. There should be a high prevalence of the disease in the community. I have given you the best example in corona. There should be a recognizable latent or early asymptomatic phase. There is in corona. Many people, they have mild symptoms, they have got a pre-symptomatic or an asymptomatic phase. They go for a test because they just want to take it for a travel purpose. They need a test report and they find that they are positive. Otherwise, till the time they took a test, they were absolutely asymptomatic, and even after the test, they remain asymptomatic. The natural history of the disease, including development from latent to declared disease, should be adequately understood. So therefore, the disease's natural history has to be understood. In case of corona, we are yet to come in terms with the natural history. But there are many diseases in which we know the natural history for sure. So we can apply a screening test. There is a test that can detect the disease prior to the onset of signs and symptoms. Like I told you, in case you do hemoglobin in me and you can find out whether we have got anemia, and then you can say, well, you may have a further development of serious anemia, go and take treatment, go and do some further investigation. So you can detect the disease prior to onset. Facilities should be available for confirmation of diagnosis. Once you do a screening test, it is not a full stop. You got to send the patient to the hospital and you got to chase him up, follow him up, so that he gets a confirmed diagnosis. That facility should be available. You should always follow up screening with a proper diagnosis of the people whom you have screened for a certain disease. Effective treatment of the disease exists. Like we do screening for tuberculosis, we do screening for cervical carcinoma, we do screening for anemia, diabetes, hypertension. We should have an effective treatment for the same, and there should be an agreed policy concerning whom to treat as patients. So all these 7 or 8 criteria are important for the test, for the disease. to be a part of a screening test. There is good evidence that early detection and treatment reduces morbidity and mortality. In case we can diagnose TB early, we can reduce mortality and morbidity considerably. The expected benefits of early detection exceed risks and costs. Okay, so these are the 9 criteria for the disease per se. You can remember all the 9, or at least the important 7 or 8, and reproduce them when you're asked the question on criteria of a screening test. I told you there are 2 parts to the answer. One is criteria for the disease, and they are the following. Condition should be an important health issue. There should be recognizable, latent, or asymptomatic phase. Natural history of the disease should not have been well understood. It can go this way or that way types. There is a test that can detect the disease prior to onset. Facility should be available to follow up and effective treatment. There should be an agreed policy to treat, which patients to treat, and there is good evidence that early detection and treatment helps the community reduce mortality and morbidity, and therefore expected benefits of screening far exceed the risks and the cost that you involve in a screening test. Well, we come to the heart of this chapter and the all-important criteria for the screening. That is the criteria for the tests. All of you will know and you will remember certain terms which we will use here. And you will now be clear as to why we use those terms, especially in terms of this present pandemic, Corona. Well, the criteria for the test should be, test should be acceptable. I told you, I gave you an example last time. You can't make a chap nude and do a test. He will not come to you. So it should be acceptable. He should be extending his hand and the test can be done. He need not undress in most of the screening tests. So it should be acceptable. It should be repeatable. The test can be repeated. In case it is repeated, it is equally easy to repeat it. And the test should be valid. It should be valid. I'll tell you each of these terms in a little detail after this. There are other criteria like yield, simplicity, safety, rapidity, ease of administration, and cost. Cost is a very important factor, especially in a developing country like ours. Out of the other criteria, yield is the most important. Remember this. This is an exam short note. Acceptability, I need not explain. Tests which are painful, discomforting, embarrassing, rectal, vaginal examinations are not likely to be acceptable. It should be repeatable. Tests must be given consistent results. Tests should give consistent results. You can't have a test, which is done on me now and tomorrow, and it gives 2 separate results. Repeatability depends on 3 major factors: how good the observer is, how there is less of biological or subject variation, and how less are the technical errors. So these 3 things are very, very important as far as repeatability is concerned. Now, what is observer variation? Intra-observer. I take your BP just now, and I take your BP after 2 more minutes, and I have different results. So the same observer is getting different results in you, whereas there are inter-observer variation. I take your BP, and after some time, another doctor takes your BP. So therefore, there is a difference there, and therefore that is called as inter-observer variation. Easy. I hope you can remember this. Intra-observer variation. If a single observer takes 2 measurements like BP, chest measurements and all that, it can be minimized by making an average out of the 4 or 3 readings that you take. Whereas inter-observer variation is between different observers. They are difference in interpretation of X-rays, ECGs, and readings of BP and all that. That has to be minimized. And for that, we require standardized protocols. Well, they can be minimized by standardization of procedures for observation, measurements, and classifications. There should be intensive training of all doctors, observers, healthcare workers. We should be properly trained. If I am not training you to take BP and I am giving you a degree of MBBS, I am a criminal in that sense. I must give you that skill also. And one must make use of 2 or more observers for a proper, independent, and impartial kind of assessment. Biological variation. This is because the individual's blood pressure, blood sugar, cholesterol, they keep varying. Our parameters are all dynamic. The changes in parameters are all dynamic. There are variations in the ways patients perceive their symptoms, and we can always repeat measurements, therefore, to reduce biological variation. So biological variation is the variation due to the individual's own parameters. And finally, something which you cannot afford in today's times, where the patient is also very, very educated. He has already Googled everything and come to you. So errors related to technical methods should be zero. There should be less or zero defective instruments. Erroneous calibration should not be there. Faulty reagents in the lab, they should not be accepted at all. They should be rejected after the expiry date. So please remember, these things need to be minimized, and errors due to technical methods should be almost zero. I talked about validity. Validity is the ability of a test to distinguish between those who have the disease from those who do not. Close your eyes and just remember this definition and understand it. Ability of a test to differentiate between those who have the disease from those who do not have the disease. Very, very important. There are drastic implications of this. You do a HIV test on a person who doesn't have HIV and say that he is HIV positive. He is shattered. He is mentally shattered. Sometimes it leads to suicides. So please remember, there are two aspects to validity or accuracy of a test. One is sensitivity and the other specificity. These words you have learned or heard or read in the newspapers in the past 6-7 months because of Corona, especially when it came to RT-PCR, that it has got 60% sensitivity. When it came to RAT, it has got 90% specificity or something, So you will have to now understand these terminologies. Specificity and sensitivity are both called collectively as validity. Now, we go back to the 2x2 table. I told this to you in the chapter on epidemiology, where when we discussed case control and cohort studies, we discussed odds ratio, we discussed relative risk and attributable risk. If you remember those lessons well, now that you have revised. So this is a 2x2 table. Here we have the diseased and here we have the not diseased. And this is exposure, which is positive exposure, and this is no exposure. And we name the 2x2 table or the columns as A, B, C, and D. And if you see, a person who's exposed to the coronavirus and diseased is a true positive. A person who is not exposed to the coronavirus and is diseased is a false negative. He may be having some other viral fever. A person who's not diseased, he is not having symptoms of corona, but he is exposed to corona, is a false positive. Whereas a person who is not exposed and not diseased, perhaps me and you, hopefully, are all true negatives. Please remember this table: true positive, false negative, true negative. Remember this from the epidemiology point of view. Remember this from the screening point of view. This is called as a 2x2 or 2x2 table. I hope all of you know this by now. Now, sensitivity was a term which was coined by a chap called Yerushalmi, and it is the ability of a test to identify the true positives. Okay? It is the ability of a test to identify the true positives. So this is where your sensitivity comes in. Okay? And needless to say, it is A by A plus C. Okay? That is what is the sensitivity. A by A plus C into a percentage, expressed as a percentage. So the number of true positives among those diseased is the true positive, or you can say sensitivity of a test, whereas specificity is the ability of a test to identify those which are true negatives. Many of you will be knowing this. Because of Corona, you will know this much more. Many of you will have studied all these things and are sure that specificity of a test is the measure of the true negatives. And what are the true negatives here? This is the true negative. The amount of true negative among those not diseased. Therefore, D by D plus B, okay, or B plus D, expressed as a percentage, is called as specificity. D by B plus D. That's why very important to know the 2 by 2 table and the columns A, B, C, and D. You have to remember this table by heart. You have to know what is a 2 by 2 table. And once you know them, you can label the true positives and the true negatives properly. This is sensitivity, this is specificity. Okay, and both of them are together called as validity. Now, there is something called as predictive value, which reflects the diagnostic power of the test. Predictive value of a positive test indicates the probability that a patient with a positive test result has, in fact, the disease in question. And therefore, if we go back to the table, it is A by A plus B. If we go horizontally, it is predictive value of a positive test. Okay? And similarly, D by C plus D is predictive value of a negative test. Predictive value of a negative test is D by C plus D. It indicates the probability that a patient with a negative test result doesn't have the disease. Your English has to be good to understand these definitions. Positive predictive value of a positive test, or positive predictive value also some people call it, indicates the probability that a patient with a positive test result has in fact the disease in question. The predictive value of a negative test indicates the probability that a patient with a negative test doesn't have the disease. Okay? So remember, what is sensitivity, what is specificity, and together they are called as validity. And there is something separate, which is called as predictive value of a test. False negatives, we already know. I just want to add a paragraph here. Implies that patients who actually have the disease are told that they do not have the disease. Dangerous. Okay? False negatives are dangerous. They have the disease. They have the disease, but they are told that you don't have the disease, and they feel very, very happy about it. And sometimes they start spreading the disease. Patients might ignore the development of signs and symptoms because they are tested as false negatives, and they may postpone their own welfare as well as spread the disease. A screening test with high sensitivity will have less false negatives, okay? Will have less false negatives. Sometimes in your clinical postings, you may be given a question or an epidemiological problem where they may ask you to calculate the percentage of false negatives. Similarly, we have got false positives, which is also a crime. Imagine you do not have the disease and you are told that you have got a disease, especially diseases like sexually transmitted infections, HIV, AIDS, because of social stigma attached to them. These have a very, very important outcome in case there are false positives. And I need not go back to the table now. I'm sure you know the table by heart. B by B plus D into 100 is the percentage of false positives, which brings us to a very, very important terminology called the yield. What is yield? When you sow some seeds in the garden, after a few months, the flowers come out, the plants come out, and then they give you flowers. The amount of previously unrecognized disease that is diagnosed as a result of screening effort. Therefore, you got some yield from your garden. You planted some onion, bulbs, and you got an onion crop. You planted some tomato seeds and you got a tomato crop. So therefore, you got an yield. I do a screening test and I pick up about 50 people from about 1,000 who are potential anemics or who have frank anemia. So therefore, I have got a yield of 50 by 1000. The amount of previously unrecognized disease that is diagnosed as a result of screening effort is called as yield. Simple thing to understand. If you remember the example of the garden or a farm, you will be able to answer this question better. Can be an exam question. As I told you, each and everything is an exam question. Okay? And you got to remember a line about each and everything. If we get that line from you in the answer, believe you me, we don't even look at the rest of the answer and we give you the marks because we know that you've done well. It depends on sensitivity and specificity, obviously, the prevalence of the disease and participation or the cooperation of the individuals. That is how the yield becomes more. In case you go and announce in a village that tomorrow we have a screening test, and in a population of about 50,000, only say about 20,000 turn up, the rest 30,000 prefer to sit at home and watch TV. Therefore, you have people who are not very, very cooperative, and your yield will definitely suffer. Well, we obviously evaluate all screening programs. Randomized controlled trials, uncontrolled trials, and other methods are there to evaluate screening programs. This is just the last part of your chapter where we have a paragraph on evaluation of screening programs. Not very important from the exam point of view, but in case a question comes in the viva or in the theory as to how will you evaluate your screening programs, you can say RCT, which we have previously dealt with, or some trials, clinical trials, or uncontrolled trials, and there are other methods, epidemiological methods like case control studies. There are descriptive studies which we covered in the chapter on epidemiology, and therefore that is called as comparison and trends between areas with different degree of screening coverage. We have almost finished the chapter on screening, or we have finished the chapter on screening. It's a short chapter. I have also rushed through it. I know that it's exam time. Within a week, that is next week, this time you will be writing your exams. I once again tell you, for the average people, read the questions which have come very often in the last few years. Look at the previous year's question papers. I think they are available in the net, or you can see some guidebook or something, or you can see in the previous year's question papers from your seniors, or whatever it is. But for the people who are good, they should read everything and take it as a revision. I want most of you to pass. That will be giving ourselves also credit that over the last few months that we have given you online classes, we have been successful in delivering the lessons to you, even if they are online, even if they are in a new mode. It will also mean that most of you, like when I see the attendance, about 100 of you are available. Most of you have not switched on your computers and they are roaming around in the house doing something else. It means that you people have genuinely attended the lectures, made notes, and studied. Remember, in your third MBBS first part, SPM is the only major and lengthy subject. I'm only comparing it with Ophthal and ENT. If you are giving 2 days or 3 days for revision of Ophthal and ENT, give 10 days for revision of community medicine. Okay? So you should be thorough in the lessons that we have covered, starting from health, epidemiology, screening, communicable diseases. Huge chapter, huge. I know it's huge, but you must pick up certain important things and read from there, including the national programs, like the National Program for Tuberculosis, like the National Program for HIV/AIDS, or the Vector-Borne Disease Control Program, or the National Urban Health Mission. All these things you must read. Then we must read about demography and family planning. Also the chapters on non-communicable diseases, which HOD ma'am took, cancers, accidents, rheumatoid heart disease, rheumatic heart disease, all these, diabetes, hypertension, they're very important, not only from the theory point of view, but also from the viva point of view. Then occupational health, sociology, which you perhaps covered in your third semester, nutrition, environment, they are all very, very important chapters. Environment is a huge chapter. very, very important: water, air, noise, ventilation, light. Then we come down to disposal of solid waste, disposal of sewage. All these things are very, very important. Yeah, I hope I'm visible now. I want to wish you all the best. And any doubts, I have shared my phone number, my mobile number with your CRs. You are free to ask, not only me, to any other faculty also. You can WhatsApp. Today's new era, we always WhatsApp or we send an email or something. You can always WhatsApp and get your doubts cleared. It is better to get even a silly doubt, which is silly as per you, cleared before you write a wrong answer in the exam. We have finished the class today. Go back to your books and study before your ophthal class starts. All the best for your exam. And thanks for attending. I see almost 120 plus people attending the class, and I'm glad. And I hope you all will do very well in your exams. All the best. Do well.